have a Thursday morning.
Yeah, we do.
First of all, thank you
Thank you.
for having me back. For those of you who don't know, in January of this year, I woke up one morning and couldn't walk. And I was pretty terrified, and I was on vacation. And I started using a cane, thinking that would help, because all I needed was a cane, I'd be fine. And as I was walking, I fell with the cane and broke my left shoulder. So suddenly, this person who was sure she could do everything for the rest of her life and not have any worries could not do anything. So I called Monica up, and she goes, well, what can I do? And I said, well, right now I'm still going to try and see people. I didn't realize my shoulder was broken at the time. I didn't realize I had spinal stenosis. I just thought, well, I can still do things. Jeff, my husband, followed me around with a walker into homes so that I could still work, because I know, he's a wonderful husband. So I had MRIs of shoulder, back, and I've been to umpteen different people. And those of you who are physical therapists, raise your hands. You guys saved my ass. Pure and simple. You saved my tail. So I started physical therapy, didn't have to have surgery on the shoulder, thank you, physical therapy. And then went into the pool and did pool stuff with the spinal stenosis. They still would like to do surgery on me, but the stenosis is all the way up my spine, which is not a good prognostic indicator. And the neurosurgeon said, I can't believe you can walk. And I said, well, I can. Well, I can't believe you can go upstairs. Well, I have to hold on, but I can. So he said, because I had a good functional outcome right now, let's put off the surgery for as long as we can, because the surgery is going to be about 6 to 8 hours. And in a skilled nursing facility for probably several months, and then they're not going to guarantee that there's any good outcome. So I decided, okay, well, let's not do surgery. Yeah, so I'm not going to do it. And so, you're fine, come on in. And so instead, I decided to reinvent myself again at 63. So I signed a contract with Greenbush, and I will go to work for them full-time starting yesterday. Retired from Children's Place on Wednesday, started with Greenbush on Thursday. And they have been phenomenal. They have been phenomenal. I interviewed on the walker, and they didn't care. And I said, but I've got a cane. And they said, well, how's your brain? And I said, well, I haven't stroked out yet. Well, I hope that brain still goes for a while. So I'll be doing 3 days a week of teletherapy from home, and 2 days a week on their different support teams. And one of the support teams is going to be housed here. At least, if you guys move, is it still housed here?
They are, yeah. Greenbush got a literacy grant for $6.5 million over 3 years, and so they're subletting one of our office spaces for the next 3 years. And so Kathy's also part of that team, and technically you have office space.
I know, I need to go look at it. Beth said it was right there.
Well, you're moving more.
I should check it out.
Yeah, we have more space for
So anyway, I'm very excited about this new opportunity. I'm very humbled. At 63, I can still can do some stuff. So, yeah. So Monica said, we've had a lot of questions about tongue tie and lip tie, and I said, well, hopefully they're not doing it. And she said, well, not so much. And I said, well, let's go ahead and let me do the full 9 yards and do my prezi. You guys know how I like prezzies. I still like prezzies. I also have one, if we have some time at the end, I did a big one on selective mutism, and I know that that's also been a huge issue. So if we whip through this tongue tie, lip tie thing pretty quickly, I'd love to pull up the selective mutism one and kind of go through some of the current literature on that as well for you guys. Because I just love being a speech path. 63 and not walking away. So, this is called ankyloglossia, and Kotlow has classifications for it, but basically it's the congenital anomaly detected soon after birth, partial fusion or total fusion of the tongue to the floor of the mouth. Okay? The person who continually moves forward on this is Kotlow, who, guess his occupation, just guess. Who's surgeon?
Dentist.
Dentist. And he's a dentist. Okay? So he came up with an anterior tongue tie classification. And what he's looking at is the difference between where the frenulum attaches to the tongue and how much movement the tongue has, the length. So when it says 1.5 inches or 16 millimeters, that's how much the tongue has passed where the frenulum first attaches. And that's what he called normal. When you look at how he classified things, there's not an awful lot of data to support all of that, but we won't go there, okay?
Just a question, will this be available for us? I want to know how much I should be writing down during this and how much I should be
Oh,
paying
shoot,
attention.
stupid me. I can save it as a PDF, of course, and send it to you today, and then you can print it out. I'm sorry.
No, that's
Okay,
okay.
great.
I just wanted to know ahead of time so that I knew how much I
No,
should be
by all
writing
means,
and
you
how
should
much-
have this as a
We
PDF.
only need to
Yeah.
print out
Yeah.
and just keep it in our.
Yeah,
Yeah, you can definitely have it as a PDF, and I totally spaced that out.
no, that's
Awesome.
perfectly
No, that
fine.
works.
63,
Well,
I got all the brain.
Everyone's asking me, should I take notes? I'm like, no, just listen.
Yes, I know, I'm just gonna
Well,
close
and
this.
ask questions, because this is a huge issue in this area in particular, which is, believe it or not, it's not a huge issue in other areas. And I honestly feel like it's, I can explain to you why. So
So
anyway,
I have a question before you move on from this, and you might not know, but when he's measuring, is this like he's just sort of bringing their tongue out, or is it like they're really sticking
Well,
their
let me
tongue
show
out,
it.
or oh,
There we go.
so here you go. So this is the actual classification. So where you see the yellow line up here, that's what he's measuring. So he's measuring from where the frenulum attaches to the end of the tongue tip, okay? And class 1 would be mild, which that looks pretty normal to me, but you know, who am I? Class 2 he called moderate. This he called severe, which I probably agree with that. Here he called that total fusion, which is class 4 is totally attached, okay? So, speech paths, our job as speech paths and as OT's feeding is to do that oral mech, right? And part of the oral mech could certainly be a classification of the tongue and the tongue movement. And these would be the tools that are out there for you to use, okay, when you're trying to do that. So you certainly want to look at that, right? Then a lot of you asked me questions about posterior tongue tie, or submucous tongue tie. And that's when it's kind of hidden under the tongue, also known as the submucous tongue tie. It's not visible to the eye. And you know when you check for a submucous cleft palate, you know, you do that finger sweep when you hope they don't bite you, because hopefully you have a spoon in there to keep the mouth from closing down on you. You can do the same thing under the tongue as well. Sometimes it gets misdiagnosed as a short tongue, which kind of I'm always wondering who diagnosed that. But if you run your finger under the mucosal lining, you can feel a slight bump under the lining, and the tongue tip may dimple, and this can cause significant feeding issues. I'm going to say right up front, over and over and over again, tongue tie can cause significant feeding issues with latching. Not so much on the speech issues, but significant feeding issues with latching. And there's a picture of a submucous tongue tie. You can kind of see right here the little notch, which would be part of that.
So Kathy, would you say the feeding issues would be with both nursing and bottle?
Yes, yes. Probably more so with the nursing because that's how children, most parents are starting with the nursing.
Right.
And that's where a lot of the literature shows us is with nursing.
Right.
But the bottle, you don't have to flange out as much with the bottle in the nipple as you do, so it's not as significant, but you do have to flange out with that nipple, with that breast.
Okay. Which is good, because I think a lot of people just associate it with, if he's not nursing, then there must be some kind of, you know, issue with this, but, and then they move to bottle and everything's fine, but it could cause issues with bottles too.
Right.
So,
So my lit search, really I kind of did it at KU before I retired from there, so I could get kind of all of their men on and stuff. I know I was totally cheating, but they were fine with it, so. I don't know, you know. But I also went on the ASHA website and did an awful lot of research there, because we have a plethora of research on that website, which I use on a consistent basis. So I was trying to figure out prevalence. How often is this? Why are we getting like 1 in 3 kids here getting clipped? You know, what's the prevalence of it? And the prevalence is really unclear in all the different research that I looked up. So what I found was less than 1% to as frequent as 97% in newborns.
Jesus.
Seriously, that's how much difference in variance there is. I felt like the most data supported one was this 2005 one with Ricky et al. That said 4 to 5% of newborns could have some issue of tongue tie. So then you're into, was it total tongue tie? Was it class 1, class 2, class 3, class 4? Where did it lie? And that information was not differentiated in the research, so it wasn't helpful. Okay, well, from my perspective. So there is plenty of evidence that good speech is totally possible. Let me say that again. Good speech is totally possible with significant tongue tie, okay? And any speech problems, even with a significant tongue tie, can be overcome without a frenulotomy. I used to call it frenulectomy, so when it came out otomy, I was kind of confused with speech therapy. So I have had adults in TBI situations and stroke situations where they could not protrude their tongue past their teeth because of their tongue tie, and their speech was perfect. Just FYI. So even though you see a total tongue tie, totally tied to the roof of the mouth or to the floor of the mouth, speech was totally fine. And there is a significant amount of evidence that shows that. So let me say that again. There is a significant amount of evidence on the ASHA website, those of you that are ASHA members, that show with a significant tongue tie, you can have perfect speech. So this is why ASHA says, what? You know, what do you clip on the tongue for perfect speech? You don't need to do that. So, sorry, I zoomed in on that. Now let's go to the lip tie, because this is going to be a combo lip tie, tongue tie presentation, okay? So it's found when the thin membrane attaching the lip to the gum line is tight, okay? Research has found, again, all the research supporting any kind of clipping finds that it's all due to lactation and breastfeeding journals, not for speech. But I just want to make sure that if you're feeding, you know, that's something you might want to look at, although we hope the majority of that is caught before the child is discharged from the hospital. But they can't latch securely and continually to the breast for nursing. And you get loud clicking sounds, those of you that are doing it, because they can't latch. So their tongue is overworking and their lip is not. So you get those sucking sounds. And then the mother will complain of nipple pain. Sometimes when the mother complains of nipple pain, I have to kind of look at the mother and does she have a high tolerance for pain or a low tolerance for pain? Is she complaining about everything? Is she in postpartum depression? Are we dealing with other emotions that might be happening during this time, which is a very horrible time for new moms when anything goes wrong, this immediate, you know, what am I doing wrong? I've done something wrong, or oh my gosh, the baby must have something wrong with it because the baby's not doing this. So keep all of that in mind when you're working with these families, because that's huge when you walk into those homes. You guys do. And again, here's Lawrence Cutlow with his little lactose journal and his thing, and he's a nice guy, and they mean well. But you know, I'll show you the video, and then you guys can make a decision for yourself. So there's a little baby with significant lip tie. So, systematic review. Let's see if this zooms in. No, zoomed in wrong, sorry. Let me back it up. No research is available that links tongue tie to speech issues. No research is available that links tongue tie to speech issues. There is evidence that clipping the frenulum has improved breastfeeding, but not speech. There is evidence that clipping the frenulum has improved breastfeeding, but not speech.
So then Kathy, would that mean no research because they haven't researched it?
No.
Or is it really there's no research has been done that doesn't prove it?
No, they've done a significant amount of research on it, and it's not proven to be effective at all.
So what about for the older kids who, like I have a little boy who's like 5 years old now, that this past summer had 3 or 4 ties clipped, and he's for his entire life has not been, like, he won't eat. He just won't eat. He won't eat. He won't eat. And so then over this, like, early spring-ish, or maybe it was last fall, somebody had said, well, I wonder, you know, like, I feel like he's got a tongue tie. And so then they went and this summer had some pretty, handled it like a champ, but they're doing a lot of, you know, the stretching and the exercises to keep it from reattaching and scar tissue and whatnot. But is there any evidence to show that it helps?
So what are you saying that it helped with?
It's been done so recently that either they haven't seen any improvement or they're not going to see any improvement. So I don't know yet.
So feeding was the reason it was done, which there's a lot of research to support that it needs, you know, for
in
feeding.
older kids?
Well, not older kids, no. But again, I think if you're going to look at whether it's going to help speech or feeding, I think you're going to go back to the feeding, the Motor Act.
Speech, he's a pretty good, I mean, he talks well.
Talks totally fine.
Yeah.
Imagine that.
Oh, right, yeah. Imagine that.
Yeah. But I definitely feel like feeding issues, we always need to be looking at.
Okay.
Okay, we just need to be looking at it. So, the effect of tongue tie on breastfeeding and speech articulation, and here I go with my other little buy-in. There is no data in the literature on any association between tongue tie and speech difficulties. Therefore, this is ASHA. We cannot recommend tongue tie division in early infancy for the indication of or the prevention of future articulation problems. We don't recommend it. It's not recommended. We don't recommend it. It's not recommended.
I feel like when I got into early intervention 15 years ago, this was happening. And then it stopped, and now it's happening again.
And I wonder if it's due to, well, and I'm going to show you some other research that kind of explains what it's due to, because nobody believes the research. I'm just like, why don't you believe the research? But, in this current philosophy where we're at now, in our society, we don't believe science. And so I'm wondering if some of that has kind of come down the pipe with some of this. But Ash is pretty adamant about it, that it's a medical decision to surgically change the oral cavity by clipping a tongue or a lip. That's tied in that although that might appear to be significant at birth, what ASHA has also shown and research has shown, the oral cavity changes over time, and we all know that. The face grows up and out, and as it grows up and out, it changes in size, and the lingual frenulum changes. It recedes, many times it ruptures on its own without anybody doing any kind of medical intervention. So ASHA's very sure about, looking at that as a medical aspect and not looking at it to improve speech. Okay?
Is it because of the breastfeeding influx though? Like, I feel like so many people, as soon as they have latching issues, I'm at that age where lots of friends are having babies, so I feel like they're clipping it so early in hopes of mom's milk not drying up while they're having latching issues because the pump wasn't
That's a really valid way of looking at it. The thing that I get concerned about sometimes is if you don't have a good lactation person looking at that latch to determine, do you have good flanging out of that lip? And I'm going to show a video here with a baby's nursing, which kind of can give you some perspective on it too. And we are seeing an increase in breastfeeding just because it's better for the child, and so we're advocating it more. But that hospital should catch that before they discharge. And so if they haven't caught it before they discharge, part of me wonders, did everything look good at that initial, and then they get home and maybe you have other issues that are coming to play, which is why I would go back to that hospital lactation consultant to find out, did you catch this at the time? Did you look at the latch? Was the latch good or was it not good? Or did you not think that there was a problem because when you first walked in and looked, everything looked like it was fine and you just walked out? So you kind of have to ask yourself, some critical thinking skills when you're looking at that. Because the vast majority of them are caught before they get discharged from the hospital. And if they're not caught, then I'm thinking, are other things coming to play? Because I have walked into homes where the latch was good and the baby was nursing, but the mom had so many issues going on. Anxiety, postpartum depression, new mom issues. The baby was freaking out because the mom was freaking out. The baby had some colic, and we had some other dietary things that were probably going on. So I felt like it wasn't the latch that was actually the concern, but all these other issues. So I always questioned myself, what's actually going on here. Make sense?
Yeah, but
Yeah.
then do you feel like sometimes in that situation, if a lactation consultant isn't brought back into the picture, that sometimes it's more of a, I don't know what to do, and I feel like the baby's not latching, so then they just identify these tongue and lip ties that may not even be contributing.
Yeah,
but they're
and why,
just doing it
and why
as
would
like
they,
a,
and why
let's
would
just
they
go
do
through
it? But why would they do that? Why would they go that route? 'Cause that's a really good question, and I ask that all the time. Why would they go that route? Because that's
Easy
it's
Quick fix.
It's fixable, right? Well, I'll just take them to the doctor. They'll just clip their tongue, and then everything will be fine. They'll just clip their lip, and everything will be fine.
Okay.
And then guess what happens?
Nothing changes.
That's not fine.
Okay.
So you didn't get the outcome that you were wanting, and so then you're back at square one, and you put this child through a medical procedure. That when you watch this medical procedure, let's see how you guys think about it.
I'm amazed that
I know,
and
because you're old like me.
They stay seasoned. They stay seasoned.
You're experienced, right?
homes and the parents talk about what their baby went through, Like, oh, wow, that is what a decision. But that is the parent tongue tie group in Kansas, that's what it's all about, is because of feeding, breastfeeding when they're born. They're not talking about, well, people come on with kids that are older that talk about, speech, but no, it's all about feeding, breastfeeding, and so there's a couple of names that they go to, as you well know.
So let's look at functional effect, okay? Because I've gotten into debates with many, many other speech paths about this issue, and dentists and, feeding people. So we have 4 issues that we're looking at. We're looking at feeding, dentition, cosmetics, and speech, okay? Those are the 4 main issues. So when we're looking at feeding, 25% of newborns with tongue tie will have latching issues. The majority have no early feeding issues. Okay, let me repeat that. This is research. 25% of newborns with tongue tie will have latching issues, but the majority of that 25% have no early feeding issues, okay? So they were still able to feed. They were still able to grow. They were still able to do fine, even though they had some initial latching issues, okay? When a person gets older, what some of my my geriatric speech paths are telling me, that they've noticed issues because their cognitive function is impaired because they're in rehab for a stroke or something. And so the movement is hard, so they're not able to clear the oral cavity because their tongue's tied and they're not able to move it around. And then they get this chronic halitosis. And then they also look at dental decay. So they're concerned about that. And so then I say, well, could you just give them a toothache, and have them go in there and clean their oral cavity and learn that way if their tongue's not able to move it? Because if you go in and you clip their tongue after they've had the stroke, how's that going to help, with all these other issues anyway? So anyway, the feeding issues has been a biggie, and I wanted to make sure I put in my geriatric SLP who argued with me significantly one day. And then on the dental issues, you guys see my smile, and I have my nice little space. I had my tongue and lip clipped when I was 12 months. And I still have the little split, which my mother called her spitter split, and my grandmother said it was, the sign of the family. But and Katie had hers filled in over the dentist. She didn't want to have
I call it the David Letterman.
Yeah, I mean
That's what I
seriously.
call it,
So
'cause
anyway,
he's got that.
they say that if you clip the frenulum or clip the tongue, that you'll prevent some of this. But I wonder about that because I had mine clipped and mine's still there. What do I know? I had this argument just the other day with another speech path who said that, well, what about French kissing? And what about licking ice cream cones and licking popsicles? And I said, of course, what about it? Many people do it just fine, even though they're totally tied down. And they, well, it looks like forked tongue, and people will make fun of them. Will people make fun of them? Are you fearful that that might happen? So anyway, a lot of people will have it done for cosmetic issues. Which I'm just like, can't we have some differences in the world and be okay with that? That's just me. Okay, here we go again, speeches. Through the centuries, it has been a common belief that tongue tie causes speech defects. Through the centuries, there is common belief. There is no empirical data, no empirical evidence in the literature that supports that statement. On the contrary, this assumption has been disputed. 63, 71, 2003, and that's just a few that I've made room for. The list was this long that has been disputed. So both tongue tie and speech problems commonly occur in children. Co-occurrence does not mean there is a causal relationship. Because they co-occur together doesn't mean that one causes the other. Okay? So, does tongue tie cause speech problems?
No.
Is there any evidence to support that?
No.
Yes, there is evidence to support that tongue tie does not cause.
Oh.
Yeah, there's lots of evidence to support that. Sorry. Sorry, it was a double negative. Okay, now, when you're watching this, and this is a little hard to watch, okay? But when you're watching this, I want you to look at what the baby's doing. They put in soft music in the background so that you're listening to soft music, but I want you to watch what's really happening to that baby. Yeah, you can get it.
Therefore, effective breastfeeding to occur, a good latch is required.
Okay, I'm not getting the audio, and I think it's because I'm not sounding.
Unfortunately, difficulties with breastfeeding may occur due to a condition called upper lip tie. In this situation, the newborn's
Let me know if you want me to come over.
I want you guys to be able to hear this, so I'm gonna pause it and take.
Well, it's plugged into your speaker, so see if you can turn up that
Speaker.
See that
speaker. Yeah, turn that up.
She's already turned.
And if it's turned up, that means your computer volume is probably down.
So go to my volume thing. There you go.
Look at you problem solving.
Hey.
Executive functioning.
Brain's fine.
Now maybe.
Your brain's fine.
Brain's fine.
Okay, let's go back.
In order for effective breastfeeding to occur, a good latch
This
is
is the
required
nipple.
between the infant mouth and the breast.
It gets pulled all the way down.
Unfortunately, difficulties with breastfeeding may occur due to a condition called upper lip tie. In this situation, the newborn's upper lip does not curl up or flare out enough, resulting in loss of suction and the nipple to be incompletely engaged within the mouth. Symptoms for the mother include prolonged feedings, painful nipples, and decreased milk production, while infants may exhibit noisy suckling and gas pains. Numbing is first applied topically using Q-tips. The upper lip tie is then clamped for about 10 seconds to crush blood vessels in order to minimize bleeding after the release is performed. Scissors are used to incise the upper lip tie, thereby releasing the upper lip to more easily curl up during breastfeeding.
Just did it falling. Dear God, that done. But you showed it to me.
What was the baby doing?
Crying.
Screaming, crying. What is that?
Trauma.
Yes. Who said that? Thank you. That was medical trauma. Okay. So, what does medical trauma do to the brain? It alters. It alters brain function. Ongoing and significant. This was a one-time thing, but it still will significantly impact that infant next time you pass them off to somebody. So here comes the next one. This is using the laser, which is what's done around here, right? Notice all these people, they're dentists. Just FYI. It's a medical procedure.
This is the best way.
Right. Saw that. Oh my God.
Okay. You can find anything on YouTube. But that's what happens to infants. They get, oh, I can't see over there. That's what happens to an infant. It has to go through this, which, I don't know, it just bothers me greatly on many levels, but
What is the recovery like for that?
immediate,
Oh, it's.
other than social emotional damage.
Okay.
That has happened due to pulling baby out. Other than that. But physically,
Other than that.
Kathy, I had a family within the last year that their chiropractor recommended it, and their dentist did it without any anesthesia. And this was a kid who was 18 months or 2 years old, and it was months probably before they could even brush their teeth again.
Wouldn't let him in their mouth.
Right.
It's terrifying.
Either.
So again, I think that's more social emotional than actual physical, but the social emotional damage is huge. Plus the thing that bothers me about the whole thing is anytime you do a procedure on skin, on tissue, we know what that causes, right? It causes scar tissue. And so you're gonna have this buildup of scar tissue, and you and I, Diane, worked with a little one who went back I don't know how many different revisions of her tongue, and still did not have good speech outcome, you know, I mean, duh, because there wasn't a causal relationship there, but that mom was sure that there was. And this kid had significant scar tissue, went back in for revisions and continued to be held down and tortured, and it was awful.
So why haven't, and I mean, this might be a stupid question, you know, when you get your tubes in, they put you under, why haven't they started doing that for these procedures? Do
Well,
they feel like that
who typically
risk isn't?
Because
It's
they're
a
not
dentist
physicians.
doing it.
That's true, you're just in a dentist office.
Who does the tubes?
Physicians.
Yeah, and where is it usually done at?
At a hospital,
Yeah.
unless they have the surgery room in their office.
Right.
Yeah,
Whereas this procedure is being done in dentist offices,
right, so it's not like it's
They can
sterile
only
surgery
use-
room.
which would scare the hell out of me if I took my baby over to that.
And parents don't want their infant under anesthesia.
Right.
Right, I mean, that's a
And
whole nother
so
risk.
They hang on to the fact that they're told, okay, as soon as this is done, you'll be nursing, and that will comfort your baby.
As soon as this is done, they'll be talking just fine.
Uh-huh, yes. And
And we were talking this morning with another family that they're starting to do tubes without total anesthesia. So I don't know if that means you have like twilight anesthesia or
That's what I
whatever,
was
but
told with my-
Really?
With one of my most recent ones that went into Mercy, that they don't really put them totally under. Because it's so hard to bring them back up, and they don't need them under that long, so. But again, I worry about, because they put their heads in kind of those little blocks to hold them still so they can kind of get in there, so I always wonder what that does if you're not totally under, how freaked out are you on? Because I wake up during surgery, I have some kind of weird condition, and when I wake up, you're intubated and your eyes are closed, and nobody knows that you're awake, and I'm kind of like, what if I breathe faster? Can you tell if I breathe faster?
Oh my God.
So, I mean, it's very scary.
Do your
And so I
eyes
wonder about
open?
little- Pardon?
Your eyes don't open.
No, 'cause
Paralyzed.
You're closed.
Paralyzed.
You're paralyzed, but consciously and you can feel everything.
Oh, God.
And then you think, pass out, pass out.
Yeah.
So anyway, this next slide,
That's why she's not
again,
having surgery.
very
Yeah.
little tongue movement is required for the production of accurate speech sounds. People with tongue tie have perfect speech. Despite reports and lack of evidence, many professionals still feel it is a common cause for speech. 60% of ENTs feel it is, 50% of SLPs, and 23% of pediatricians. So even though there's a significant amount of evidence to show that it does not cause speech problems, people still feel it does. And that's why they're out there reporting it, recommending it. Uh-oh, back up.
And do you know what the percent or chance of reoccurrence is? Like if
No.
it,
I do not, that's a good question. I do not. I did not look it back up for reattaching.
Yeah.
Typically, I would think that it would be low, just from, if you do a critical thinking about the face growing up and out, that, you know, you wouldn't have that way, but I don't know.
yeah.
I didn't find anything on literature, but neither did I say reattaching. So maybe if I would put that into the search mode, something would have come up. I don't know.
they do have to do a lot after to prevent adhesions that can then help that reattach.
Scar.
That's one of the main, which also adds to the trauma for the poor little child.
Yeah.
All because. Right. So I always get this question, so I just thought I'd put a slide in on it. What could it hurt? It's an unnecessary medical procedure. It's a traumatic event for a very young child. And I would never want a child to go through any kind of trauma that was unnecessary. Because the impact on the brain to a traumatic event, even a one time, can be lifelong. And I want to always keep that in mind. If you have a one-time event of living through a flood, or living through a fire, or being a child being sexually abused, or being a medical procedure. I look at my cleft lip and palate babies to this day, as they get older and older, still remember, still are traumatized by the event. So it's a traumatic event. So you don't want to have that, right? Traumatic events are not good. And it causes scar tissue, the healing, infection, and surgeries can go wrong. And it may not result in the desired outcome. You wanted better speech, but you still don't have it. And I try to bring this up to people, that speech is a motor act that's driven by language, right? So when we look at the principles of motor learning, if a child has already, you got a little, 18-month-old, 12-month-old who's starting to talk, they're starting to learn it, but they didn't talk as quick as their older brother or their older sister, so their parents kind of freaked out because, they need to go in and look at it. Oh my gosh, their chiropractor said, well, they're tongue-tied, that's why they're not talking, I need to go ahead and work on that. So that little 12-month-old was just starting to figure out how to move that tongue, how to move those lips, to be able to start to make those sounds, and they were just playing around with it. When we go in and we change that and alter that by clipping things. So again, then they have to relearn that principles of motor learning, which they were just starting to pattern. So that bothers me too, on many levels. So, ta-da! Tongue, lip tie, to clip or not to clip, an examination. You might want to clip or look at clipping for latching and for feeding issues, but never for speech. There's no evidence to support it for improving speech, none.
So I have a question, because sometimes, and I haven't seen this until recently, but like, you'll get the report that, oh, he had like 8 tongue ties. What is that? Like, what does it look like? Is that like 8 underneath? Is that, I mean, are they making up that there's tongue ties that aren't there? How do you have 8 tongue ties in your mouth, and then I look in the mouth and it looks completely normal?
Yeah, there's the anterior and the posterior. That's the only 2 tongue ties that I know of.
Right.
And then there's the frenulum, the upper lip, and the lower lip. Those are the only other 2.
What about
so-
somebody,
so-
I've heard buckle a lot.
Mhm.
Tell us how you really feel.
I only know of the anterior and the posterior on the tongue,
Yeah.
and then the same way with the lip. Those are the only ones that are in the research.
Right. It's just hard to answer, like when a parent's like, well, what does that look like? I'm like, I don't know. I don't
I would
know
ask
where
them
those
to-
7 tongue ties came
I
from
would
that
ask
were
them to
clipped.
ask that medical professional to show them.
Yeah, yeah.
Yeah, to go back to the medical professional that recommended it and just show them. And then I would also ask for evidence to support that it's going to be helpful.
I'm still confused on where the posterior is. I thought it meant at the back bilaterally.
So did I.
Me too.
That's what I
The
always thought.
frenulum though is one line going back. So the
Okay.
frenulum is still just that one.
It would still affect anterior too.
Right, because they'd have to clip that to get to the other.
So
Which
it's
you have to
not,
feel for. And I felt like that one dentist was kind of feeling for it after he did the anterior. I felt like he was feeling for the posterior and then kind of let it go.
okay.
But I also wondered why, and of course this is just YouTube videos, so who knows why. But looking at the tongue and the class of attachment that there would be, I didn't feel like any of those were severely attached, nor did I feel like I saw any on all the video that I looked at before I picked those 2. I tried to pick 2 that were, one that showed clipping, which was the old way of doing it, which some people are still doing, and then one to show the laser, which is what's happening here. So,
Kathy, are you finding the prevalence of clipping is with the dentist over the ENTs in this area?
I don't know for sure, Mariel, but I would say probably yes. Those are the ones I hear about, but I don't know if I hear about them because they're dentist, I don't know. But yeah.
Because the
This-
statistics showed a high number of ENTs being pro. So why would there be more dentists doing it, not the ENTs?
Because who has the laser? Who was sold the laser?
Yeah. Oh, yeah, that was a commercial for that laser, so I guess. That's kind of stilted in that particular one, I guess.
This may not tie in, but like I go back to thinking, okay, so after surgeries like this, oftentimes oral motor exercises are recommended. And how does that play into speech? Because I feel like that's something that will come up a lot. And again, what does the research tell us about quote unquote oral motor exercises for speech?
The research shows that a different part of the brain is activated for oral motor exercises versus speech. And so if you're doing oral motor exercises, you're activating the motor part of the brain, not the language part of the brain, which is what the speech drives the speech. So doing oral motor exercises is not recommended for improved speech. So then the research there is pretty hardcore to not recommend it.
Yeah, just because we don't need that much,
You don't need that much movement, yeah, you really don't. The thing about it that is always hard is that when you look at it, you think, well, speech is a motor act. Because you move your lips, you move your tongue, you gotta move those things, because you're moving them, so if they're inhibited in movement, then therefore it's gonna be hard for speech. But it doesn't translate to that when you think about the brain interacting with those articulators. The speech center of the brain, the language center is what's most active. So if you want language and speech, you have to work on language and speech. Even though back in the day, I did it, 30 years ago, that's what we were told to do. And 30 years ago, I was right there with everybody else with my, well, and tongue depressors and, lollipops and everything else to try to get the tongue to go different ways. When I thought back on all that, because when research was first coming out, I was like vehemently opposed to it. Because it'd been working for me, right? I've been doing it, it'd been working. I looked back at what I was actually doing, and I feel like what I was actually doing was giving a physical prompt to stimulate movement, and I immediately moved it to a speech act. So I would say, here's your lips, close your lips, and say, ba, 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 close your lips, ba, ba, ba. So even though it was, I was doing some of those oral motor exercises, like here's your tongue, right here, feel it candy on your tongue. I want your tongue to come up high, come up right up here behind your teeth. So I feel like maybe I was doing more of a physical prompt than I was actually doing an oral motor exercise per se. Although I did go ooh, ee, but then I was going ooh, I was adding a vowel to it. So, I don't know. I always analyze what I do, like am I having efficacy behind my treatment, because you should, right? You shouldn't be doing something just for the sake of doing it.
Well, and that line between is this just pure oral motor, or are we having fun with different sounds in the mirror and stuff like that?
Playing with sounds and exploring your
Right.
articulators and how they move, and
So,
and we're dealing with babies. You should be playing with them. It should be fun. You should be exploring different things and allowing them to explore it as well. So,
right.
yeah.
Or even just when you're pretending to blow or something like that, blowing is oral motor, but are we also working on imitation skills and play and, I'm going to do this and you're going to do that.
Yeah. Yeah.
So.
And cause and effect,
And cause and effect,
Yeah.
yes.
Yeah. Children's Mercy, their cleft lip and palate team just hate bubbles. And so they will tell their parents as they discharge them, if your therapist is working on blowing bubbles, you got the wrong person. So just FYI, as you get those cleft lip and palate babies from CMH, you might explain to the parent up front, that I'm just playing. Bubbles are fun, they're like the magic tool for every speech path, and we're not actually
What do
trying
they
to-
hate about bubbles?
Well, because they feel like you're going back to oral motor exercises and puckering and spreading and blowing, and that you're not actually working on speech.
As opposed to to try to talk about
Exactly, exactly, which is so the minute a parent will see you with bubbles, if they just come from that clinic team, they might be like, you're on speech path, so you just might know that as you're working with those children, you might explain to the parent up front what you're doing and why you're doing it, which is what you guys do anyway, so.
It elicits language though when you're doing it.
Oh, yeah.
Bubbles are the magic
Bubbles
tool.
are magic.
Bubbles are the magic tool. Yeah, well, they do though. They say that a lot. So just FYI.
Wow.
When you get those babies, make sure that you explain to the parent what you are working on.
Yeah.
I think that that's the piece behind what we do, always explaining what you're doing, coaching the families, and don't
Yeah,
just go in and do because they don't know. It's like a vowel. It's like they don't know all of the things we're looking at.
They don't.
And so it's our job to let them know and share that information. So I think that's a really, really good point from everything we do, from the evals to intervention and the follow-up.
Because we know that if we grow the capacity of that parent's going to be able to follow through when you're not around. And so that is your goal, is to help that parent understand what you're doing and then watch them do it and see if you can coach them through that.
Well, if you tell them why, they'll buy into it more too, and
Sometimes
follow
you-
through better.
Well, you hope.
Probably, yeah. In
They're
theory.
like, go to the bathroom. Come back. I'll be on the phone.
So, this, you don't have to, but I thought it would be interesting, we were talking about, having an attached pendulum and it not affecting speech. I personally know at least 2 adults that had pretty significant attached frenulums, my brother-in-law and a good friend of mine, that neither of their speech was affected. In fact, I knew my brother-in-law for like 7 years before I even knew it. And then, of course, I embarrassed him in the restaurant because I kept like wanting to look in his mouth and stuff, so.
Mine was totally attached as a teenager, and I used to stick popsicle sticks, I remember, through my teeth.
Oh, wow.
And maybe not as a teenager that far, but a Dorito took care of it. And I never had any speech issues
Right.
from, I mean, I was an early fast
I
talker.
remember, so
Yeah.
the first time I saw it fully attached, I was doing PRN stuff at Children's Mercy for their rehab. And so we'd gotten a girl in with significant, inflammation of the brain. Thank you. Encephalitis. And we were working on seeing if she could imitate. She was still intubated at the time. She was still pretty involved. And so I was trying to get her to imitate oral movements. That's kind of the first thing you do when you check out everything. And I immediately was like, oh, she can't stick her tongue out past her teeth. Oh my gosh. And of course I was just busy writing, going through my checklist, looking, and then the dad went, she'd never been able to do that.
Oh,
And I was like,
there you go.
oh, really? And they goes, no, she's totally tied. I was like, oh, well, how's her speech? Totally fine. So how's her feeding and swallowing? Totally fine. It's like, okay, well, then we'll just
Move on.
Yeah, move on. But the first time I saw it, I was like, oh my gosh, you know, and you could see the tip all the way up of the frenulum, all the way over the tip of the tongue. I mean, it was totally anchored.
I just think it's interesting, like in this room, probably all of us know of at least one person that it didn't affect their speech. But I think it would be hard to be like, oh, I know someone and they had a really bad speech impediment, you know, as we
That's
would
right.
say is when we get.
That's right.
So.
Well, and you know, so now let's talk about moving forward, okay?
Yeah.
So now I've shared this information with you, or will as soon as I can download it as a PDF and send it to Monica, and we'll send it out to you guys. You got a parent that's saying, well, we're gonna take them in next week and have their tongue tipped, so or tongue clipped, so we won't need you anymore. How do you respond?
I don't think, has anyone said that?
I did, I had to
Really?
say it. Oh, yeah, I totally had to say it.
Wow.
We won't need you anymore.
This will solve it.
Yeah, this will solve the problem.
I would say, well,
We're here when you need
Yeah.
us.
And I would also try to
Do
add
the
a little bit
research.
to that, to say, you know, I just went to a training, and there is no evidence to support that that's going to improve speech sounds production. And so you might ask your provider who's performing this service what evidence they have that it will, because the evidence that I've been shown shows that it won't. So you might be putting your child through a medical procedure that may not net you the outcome that you want. And I'm just sharing that information with you, and what you do with that information is certainly up to you as a parent, because I would never say that, you know, you as a parent don't do what you feel like is right for your child, but I just want to share that information with you.
Kathy, are you aware of research, because obviously this is for our very, very young ones, but are you aware of more research that's being done? Because I've read some articles on older adults and older children, and it doesn't have anything to do with feeding, and it doesn't have anything to do with their speech, but it's having more to do with facial growth, because maybe they had a history of not breastfeeding, and they went straight to bottle feeding for whatever the reason might have been. And so then things are kind of shortened, and then they're finding that your tracheal openings as adults are getting smaller than they should have been if maybe you had a more natural suck.
I guess I would be wondering about the
And so
growth plate.
sleep apnea has kind of been, that's what the article was saying, like some sleep apnea issues they're kind of wondering if there's a link to some of these.
And I wonder about
things.
micronathia.
Right.
And I wonder about growth plates. And I wonder if that's what's being impacted more than what they think about clipping the soft tissue. Because that would appear to be more of a structural issue that they feel like is confined by a soft tissue problem.
Right.
Which I don't know if the soft tissue is going to actually put enough pressure on that to stop that.
Right, and that's kind of, I think, what the question is.
Yeah, yeah, I would wonder about that, whether or not, because when you think about tongue thrust, which, how many times do you guys deal with tongue thrust? You know, I deal with that all the time with families, and all the research shows that the tongue thrust itself does not exert enough pressure to change the oral cavity. But the dentist wants you to fix your tongue thrust before they put, you know, all your dental work and what do we call it, braces and all that kind of stuff on your teeth, because they feel like it does impact it. But it doesn't, and their research is who shows that it doesn't impact it. So I wonder, how can you link a soft tissue issue to a structural issue?
Right.
And I don't know either, and I know I've not seen. But
Because
I would question growth plate on that.
Because more and more adults are now going in to have some of these procedures done because of some of these questions.
And part
I
of me
find that kind of
wonders if it's an
interesting.
adult, well, you know, be a critical thinker and look at that information before you go into something like that, and what could it hurt? Well, you know, you're the adult and it's happening to you, so you can be the judge of that. I guess from my perspective, I'm just looking at the little tiny ones. And no, I haven't seen any information, although, you know, I deal a lot with craniofacial anomalies.
Right.
And so I deal with these Treacher Collins and these, you know, cleft lip and palate and these who knows what individuals that come to you with, you know, micrognathia. And I have seen adults with significant micrognathia that are actually speech paths now, who were told at a young age, oh, we need to fix that. Oh my God, do you know what you have to do to fix that? You know, small, I mean, it's the full Lafort where they go in and break the bone and move the jaw forward and insert, you know, hips. Yeah, it's horrible. It's horrible. Oh my gosh, I'm so sorry. I thought I turned that off. So, I always wonder when they recommend it, because then the mother went, well, what do you think? And I said, I think she's fine. So they never did anything. And now she's a PhD speech path teaching at university with micrognathia, and she goes, well, maybe I should have had something done just for cosmetic purposes, because, you know, they're always looking at, does the nose come down and does it line up with your profile for all this? And mine doesn't, mine really recedes, and I'm like, you're beautiful. Ignore that. So, again, I don't know. It's a good question. Guys, it's so much fun to come back and see you.
I know. I'm like, can we do the select the mutism?
Should I jump right into it? Are you guys okay
I
with
told
that?
everybody 11:30, so
Okay.
just jam this info down their throats. Come on.
Let me jam it in. Let me go back to my other phrases. Let's see. I've gotten a